So aquablation means that you remove the prostate tissue using water. So aqua is water, ablation is a removal of the tissue. So it's aquablation of prostate is remove the prostate tissue, and it is used in a heat-free water jet. So you have a water coming at a high pressure of 800 psi. So you can imagine it will cut through the tissue. So it's very important that you have to be precise in your landmarks, and that is the main thing about this procedure, that if you plan treatment well, you can predict the results. That's one thing that is fascinating. You will get exactly the same result in almost every patient. And I tell my patient that you're going to be peeing like a 40-year-old, even before I do the surgery. It is FDA approved. It got approval about 4 years ago. They did 2 studies before they got FDA approval. They're called Water 1 and Water 2. They were done, Water 1 was done with a group of, as a randomized double-blind, not double-blind, so double procedure study. So one group got TURP, which is the gold standard operation for BPH, and the other group got aquablation, and the prostate varied from 30 to 80 grams, which is like the moderate enlargement. And the results were very good because they compared the efficacy with the TURP, which means that the results were similar or superior, but the side effects were less than TURP. So that's what one study. The second study, they did larger glands. They did prostate size from 80 to 150 grams. And there was no comparative arm from there because you can't do TURP for that size because that's too big for TURP. But they also had excellent results with that. So they got FDA approval about 4 years ago, and I started doing this procedure about 3 years ago. Yeah, that's a very interesting question. Who is a candidate for aquablation? So you can actually, I think that any patient with BPH can have aquablation. So it varies from smaller size to bigger size gland. So 25 grams to 150 grams, which is like 6 times the normal size, or almost more than 7 times. So normal size is 20 grams. So you can imagine. You can use that for any size of gland. And that size itself is not a criteria. Now, right now, the Medicare has put a limit on 150 grams, but I have done glands larger than 150, and they've done equally well. So aquablation at this time is performed in hospital. We are trying to, I've started to do the same day surgery. So, down the road, hopefully it'll be a surgery center procedure. It is at this time it is done in the hospital. Patient is under anesthesia, and I've been sending home same day with the catheter that is taken out next day. How long it takes? It takes about, the actual resection time is about 10 minutes. And that doesn't matter which size it is. But then you have to clean out the area, you have to irrigate the prostate tissue and get some bleeders. So I would say 30 to 40 minutes time in general. The common complication of aquablation is bleeding. That's one of the common complications. That's why we've been doing combination with in some people with larger glands using embolization prior to that. So that decreases the bleeding, because one of the advantages of aquablation is that we perform, it is a heat-free, so we don't use much cautery, so to preserve the erections and ejaculation. But you have to get the main bleeders are called arterial bleeders, So bleeding is one of the main complications. Other than that, patients will have some burning, pain, some blood in the urine for a couple of weeks. As they recover, as their lining gets, new lining forms in that channel that you create with the aquablation. And that takes about 2 weeks or so. After that, really there is no real issue there. There is a condition called retrograde ejaculation, in which the semen goes back into the bladder and doesn't come out, so they get a dry climax. And those situations with aquablation, advantage is that we can prevent that in about 85% of patients. So the incidence of retrograde ejaculation is only 15% with aquablation, whereas it is about 70% with the TURP, so which is the standard procedure that you compare it with. So those are some of the side effects patients will notice. When they did the Water 1 study, comparing the aquablation to TURP, those are the things that they look for. They look for the blood loss, they look for the recovery period, they look for long-term side effects on erections and retrograde ejaculation, and the complications overall. And what they found in that study was that the results as far as the efficacy is concerned were similar. Then that TURP, which is what we are looking for, the TURP is the gold standard. Okay, so if you can get results equivalent to that, that's great. But you want a procedure that doesn't have those long-term side effects with TURP. That is, most of them are, some people get ED, erectile dysfunction, and some people get retrograde ejaculation, high incidence of that. So that is where aquablation scores higher than TURP. So it is equally efficacious and less and more safe, you can say. Okay, so what happens to prostate after aquablation is that you remove a portion of the prostate from the transition zone. Prostate is divided into different areas, different segments. And for example, peripheral zone is where the cancer is located. And BPH is located in the transition zone, which is in the middle of the prostate where it connects to the bladder. So you remove about 30%, 40% of prostate when you remove that transition zone, and that opens a big channel that you pee through and the urine flow improves, and that's why it works. What happens to that part is that it gets reepithelialized. So the new lining forms there, it becomes like a normal urethra. So some of the tissue is we just irrigate it out. The main reason why the TURP has more side effects, number one, it uses heat as the source of controlling the bleeding. So we use the cautery. Aquablation doesn't use heat, and heat is supposed to be one of the factors that causes erectile dysfunction and also ejaculatory dysfunction. So we don't use that. We use some of it, but not a lot. And that's probably the reason. Plus, you can treat bigger tissue with aquablation, larger glands than TURP. And TURP, the larger the gland, the longer it takes. And also, it requires higher skill set to do the TURP for larger glands. So people who have done many TURPs, they get better at it than residents coming out of residency, and they start doing a TURP. For them, 30 gram prostate may take an hour. So, so there is a learning curve that is much steeper with TURP, and as the size increases, the time taken to do the TURP increases. Whereas the aquablation, because it is very precise and robotically controlled, the handpiece that goes in there, that is controlled with the robot. So once you do the treatment planning, you start the aquablation, it tells you exactly how long it will take to do one cycle, okay, one pass. And then I usually use 2 passes, so it takes about maybe 3 to 4 minutes each pass, or 7 minutes total. Yeah, I would say 10 minutes occasionally, because you have to just put the instrument in and take it out and all that. So and after that it's just controlling the bleeders and getting the tissue. So the recovery time after aquablation, usually I tell my patient that expect about 2 weeks, that you need to avoid heavy work, strenuous activities, and mostly I tell them to avoid bumpy rides, horse riding, bike riding, and golf cart riding. So those are the things that some men love, so that they have to be aware of that. The reason is that it puts direct pressure on the prostate. It can aggravate bleeding. Other than that, right after the surgery, we take the catheter out. They should expect some blood in the urine, some burning in urination, some pain for a couple of weeks, and then it gradually gets better as it heals. As far as sex is concerned, after 1 week they can have sex if they feel comfortable, and other activities after 2 weeks they're back to normal. So when how effective is aquablation is when you look at the efficacy of any procedure, you want to have a procedure that has the highest efficacy. You want a procedure that is efficacious and safe. That's the ideal procedure. That's what we have been looking for ever since TURP was discovered. And I can go back in my residency days when we started out. There was only treatment available was TURP. And then they came up with alpha blockers and 5-alpha reductase for like finasteride and tamsulosin, Flomax. All those treatments were started. And they were not doing the same thing because the prostate continues to grow. So they came up with the next procedure to replace prostate, TURP, because patients are scared of surgery. They want something that is less invasive. So they came up with the balloon dilatation as the first option to replace TURP, but it didn't work out. Then they came with the microwave therapy, which is another procedure that fizzled out. Tuna or needle ablation of prostate using radio frequency, that also did work out very well. Green light laser, some people still use it, but I found it not to be very effective. Then we have two new procedures which we still use in our group, Zoom and Urolift. There are some indications for that in situations where it works, but you cannot use them for larger glands, and specific glands that are not suitable are the ones that go into the prostate called median lobe. So where TURP can work for all those, but TURP has a limitation of how much size prostate you can do, and then you're talking about open surgery or doing laser enucleation or HoLAP. Those are for larger glands. They take a long time, and there's a lot of morbidity involved with that. So to say exactly how efficacious is, I would tell my patient that is 90% efficacious. 90% patients will do great, and they will do. I actually say that it is even better than TURP. And my results are, obviously not everyone. Some of the patients have, where we check the flow rate. If somebody has a flow rate of 8 seconds per second, and now they have flow rate of 45 cc per second. So just imagine you're voiding about 500 cc and it takes you 15 seconds. You go to the bathroom, before you know it, they're out like their child, I've never seen that before with TURP. We have a data up to 4 years. And the data up to 4 years have really sustained results. And all my patients that I have started out, they are coming to see me, and they're still doing great. So I would think that some of them will require surgery, maybe 10 years. Usual recurrence if you just compare with historical TURP, it's like 1% per year. So about 10% of people in 10 years will get revision surgery or something, maybe a little tweak here or there, not maybe Aquablation, maybe just TURP, something to correct whatever it is. The cutting edge of Aquablation is that it is precise. I think we use the robot as a instrument. Once you put it in, you're free. You need to have an ultrasound, and you need to plan the treatment area. You have landmarks. You have to make sure that you take care of that, because if you don't, it can be problems. So you need to be very careful about that. And those are the landmarks. That's why I said you can predict the results. And I don't think there's any other procedure that really will achieve the same results. Well, can it be used for prostate cancer? The answer is no. It's not a treatment for prostate cancer. However, there are some situations where patients with prostate cancer have BPH. So it's actually very common for patients to have both. But your main idea is to treat the prostate cancer, and as a result, if they have retention or they have urinary obstruction, that you cannot really give them radiation, for example, because the urinary symptoms can get worse. In those situations, you can do Aquablation just to relieve the blockage, but you still need treatment for prostate cancer. So it's not like a treatment for prostate cancer, but it can be used as an adjunct, because some of those patients we were doing TURP, which is to relieve their obstruction, so you can replace that with Aquablation. So obviously, you have to be a urologist, naturally. The training that is required involves the lab, with the animal lab with pigs. You see that procedure, you do the procedure there, get some acclimatization, and do the training there. So after that, you see patients. You need to be proctored for few patients by somebody who has done more cases. And once you get proficient, then you can do it. Doesn't require long-term skills. I think you just refine your technique as you go along. As of yesterday, I think yesterday was 167. And I think I'm the largest Aquablation surgeon, or have the largest number of cases in USA by far, actually. So the next one is close to maybe 100, 110 or something. So I feel very comfortable with it. So if you select a patient and identify this patient will need Aquablation, the treatment protocol involves patient to be cleared by anesthesia. Obviously, the routine, pre-operative checkup. The specific thing for Aquablation is that we have them clean their rectum with a fleet enema, because you have to use the ultrasound, and you have to have a good picture of ultrasound. If there is a stool or air in the rectum, then that can cause artifact, and that can obscure the landmarks that we used to see. And they also, obviously, if they're on blood thinners, they need to stop the blood thinners. Most common question patients will ask, how effective it's going to be, and how safe it is, and will it affect their sexual function. So those are the common things. Men, obviously, they're preoccupied with that most of the time. I tell them that their sexual function will not get worse, because I have not really seen erectile dysfunction as one of the side effects. They may not get better, so they may need treatment, which obviously is not treatment for ED, but there will be some dysfunction maybe with ejaculation, because part of that could be removal of the prostate tissue, so you have less semen coming out. But ejaculation may be affected, but that's a very low percentage compared to TURP. Bleeding is minimal, so I mean, yeah, you will have tough 2 weeks, but after that you should do great. What questions patient should ask? I'm telling you, patients are very, very smart. They will know what to ask. I mean, I don't really think that there is anything. The patients want to get better. That's the main thing. They want to get better. They don't want to be mapping out where the restrooms are when they go to mall. They don't want to be going at every rest stop they stop and go to the bathroom. And their social life is affected. It is very, we underestimate the effect it creates on patients' social life. So they want to live a normal life.